Hello everyone. Today we'll discuss how to start insulin therapy. So whenever we see patients in OPD or admitted cases who are not having sugar control with OHS and all, then we'll plan for insulin therapy. So we have to know how to initiate the therapy. So first step is to consider basal insulin. So we have to try with that. Otherwise, the next option will be we can start on mixture, that is twice in a day, or we can also begin with basal plus 1 OHA, that is either DPP-4 inhibitor or GLP-1 analogs. So this should be the initial approach. What mistakes we'll do is we'll always start with rapid acting insulin first. See, whenever in the course of the diabetes, patients will have some capacity to produce insulin on their own. So for that minor quantity of insulin production, food intake is the stimulus. So obviously, whenever patient takes a meal, that will stimulate beta cells of pancreas and it will try to produce whatever is capable of. So no need to give bolus insulin in the beginning. So prefer only basal, so that baseline of the blood glucose level will be maintained, and whatever the postprandial spikes are there, that will be compensated by the whatever remnant function of the beta cells of pancreas. Suppose if the patient is not having sugar control even with that step 1, then if HbA1c is not controlled, we'll go for step 2. In this one, mainly we call it as basal plus therapy. So basal plus is we will be giving basal therapy. Along with that, we have to assess the meal pattern of the patient. So whenever there is a large meal, we will add short acting insulin for that particular meal only. This is called as basal plus therapy. Otherwise, we can increase mixed doses from twice to 3 times a day. Again, a third option was there for us in step 1, that is basal plus any one OHA. Here, again, it will follow the same pattern, basal plus short acting insulin during one large meal. So this is the step 2. As we can see in admitted patients, we will monitor GRBS thrice or 4 times a day, and we will get 2 values under control, but 1 or 2 value will not be under control. So for that particular value, we can add short acting insulin. Suppose with this regimen also, if HbA1c is not getting controlled or sugars are not getting controlled, then we will go for step number 3. In that, which is called as basal bolus regimen. So we will keep the basal dose as it is, and we will add bolus at every meal. So this is called as basal bolus regimen. And even if it is not getting controlled with this therapy of thrice mixed, we have to shift to basal bolus regimen. Same will apply to the third column also. And one more important thing here I want to add on is, whenever we are treating poorly controlled diabetes case, we have to advise for complex carbohydrates. If the individual is affordable, then we can ask the individual to change to brown rice instead of white one, or to the whole wheat chapatis, etc. But if most of the Indian population, they will not be affordable and they will not tolerate such sudden food changes. So for them, what best advice can be given is they have to take 1 carrot and 1 or half cucumber at every meals. So these can act as complex carbohydrates. So as we know, complex carbohydrates will not allow the blood sugar levels to spike. It will make sure that the whatever eaten glucose is there, it will be released in a sustained level. So this will help very much in case of poorly controlled diabetes. So try to advise your patients with these complex carbohydrates, which is very much approachable and practicable by the Indian population. Thank you so much.